We have seen about various membrane defects causing hemolysis, but in this section we are going to see certain enzyme deficiencies that can cause hemolysis. So the first and the most important enzyme deficiency that can cause hemolysis is the ever important G6PD deficiency, which is really important. And the second one that is important is the pyruvate kinase deficiency. And the third one that is important is something called a phosphofructokinase deficiency. So these are three enzyme deficiencies that are very important, which can result in hemolysis. The first G6PD, let us see about G6PD deficiency. Remember, G6PD deficiency is supposed to be the most common enzyme deficiency in the world. In fact, I am not talking about the most common enzyme deficiency causing hemolysis. The most common enzyme deficiency in the world itself overall is G6PD deficiency. It's such a common entity. Majority of the patients will be asymptomatic though, because they don't have any like severe decline in the enzyme. But apart from that, this is the most common enzyme deficiency in the world. And if you ask me why G6PD is important, you can relate to, all these three enzyme deficiencies are related to the Embden-Meyerhof pathway, that is the glycolysis. But in G6PD, you know very well, this glucose 6-phosphate 10% enters the hexose monophosphate shunt, that is HMP shunt. If you have a G6PD deficiency, and again the HMP shunt is very important for the production of NADPH. If you have G6PD deficiency, you are going to have reduced levels of NADPH. So if you ask me why NADPH is very important, you know very well, this NADPH will become NADP. This NADPH conversion to NADP is very important to restore the glutathione stores, reduce glutathione stores. Initially glutathione will be in oxidized form or non-reduced form. To make the glutathione into reduced form, or to convert the glutathione to reduced form, and to maintain the stores of reduced glutathione, this NADPH conversion to NADP is extremely important. Why this reduced glutathione is very important? We know very well, we have already discussed all this in the basic section, but still I'll recap right now. Because this reduced glutathione becomes oxidized, but it actually reduces because it pushes the hydrogen to the certain oxidizing compounds and reduces them. For example, best example I'm telling, a lot of compounds like this are the best example is hydrogen peroxide, which converts into harmless water molecules, which means if this hydrogen peroxide is not, some oxidant molecules are not converted to neutral substance like water, if it's not reduced to neutral substance like water, this is going to create oxidative damage to the cells. Oxidative damage and oxidation related damage to the cells. Typically, they are going to produce superoxide radical, they are going to produce hydroxyl radical. So many problems are there with this hydrogen peroxide and other similar oxidant molecules like this. So that is the reason why it is really important to understand the importance of NADPH. So what happens if you have a reduced NADPH? If you have a reduced NADPH, your glutathione conversion to reduced glutathione will be very poor, which means your stores of glutathione will be lost, reduced glutathione will be lost, which means your oxidative molecules cannot be reduced to harmless substances. So which means the oxidative substances amount in the cell will increase. Once it increases in the cell, your oxidative damage will increase and production of all these free radicals also will increase in amount inside the cell. So this oxidative damage, if it increases, they are going to damage proteins especially. Typically what they damage is the hemoglobin. This hemoglobin will come and settle on the RBC membrane. This is a damaged hemoglobin molecule, or otherwise you can call it as oxidized hemoglobin, or you can call it as a denatured hemoglobin or oxidized hemoglobin. That is because of excess oxygen damage due to G6PD deficiency. They come and settle in the RBC membrane. They precipitate in the RBC membrane. And this precipitation of these hemoglobin molecules over the RBC membrane is what we refer to as something called Heinz bodies. And areas that contain this damaged hemoglobin that is settled within the membrane. For example, if you have RBC with a Heinz body over here, if it's settled here and this area will be bitten off by the macrophage. The macrophage is going to bite this area off and it's going to result in something called a bite cell. Or they can form something called a blister cell, a bite cell or a blister cell, which you have seen already. Blight cell or a blister cell. That's what is going to happen. So this is what typically results in a G6PD deficiency. All these are pathophysiology of why the problem. Because all the problem G6PD is due to low production of NADPH. This is the pathophysiology. Apart from that, you need to understand there are certain triggers for G6PD deficiency. Before that, we can tell what are the types of G6PD deficiency or variants of G6PD deficiency depending on the enzyme levels. So class 1 is less than 1% enzyme only. The disease will be extremely severe and usually they will result in chronic non-spherocytic hemolytic anemia. Like G6PD deficiency really does not result in spherocytes, but autoimmune hemolytic anemias will result in spherocyte formation. But G6PD typically don't result in spherocytic formation. So chronic non-spherocytic hemolytic anemia, that's what is going to happen. It's like a chronic intravascular hemolysis. And what G6PD deficiency typically produces, if they ask you, answer will be intravascular hemolysis more than extravascular hemolysis. Or if you want a single answer in exam, you can tell intravascular hemolysis. That is very typical of a G6PD deficiency. So which means it's going to result in chronic, type 1 is going to result in chronic non-spherocytic intravascular hemolysis. And typical phase of intravascular hemolysis you will see like free hemoglobin, hemoglobinuria, dark colored urine, hemosideриnuria, and like kidney injuries. All these things can happen over time. So number 2, less than 10% severe. This will cause only acute intermittent hemolytic anemia. Acute intermittent hemolytic anemia or hemolysis. So why intermittent? Why it causes acute intermittent hemolysis? Because this acute intermittent hemolysis is going to be due to oxidant stress. Only during some stress or triggers. There are a lot of triggers which I'll tell you in some time, that only when it is triggered by some event, then only they will go for acute hemolysis. Otherwise, they will not have hemolysis, they will be normal. But this is something with or without trigger. Type 1 will be chronically having hemolysis. But type 2 only during acute attacks or triggers they will have hemolysis. And 3, if you ask me, it is 10 to 60% moderate, and you will have occasional only, not frequent. This is frequent actually. Acute and frequent hemolytic anemias with occasional hemolysis will happen, hemolytic anemias will happen only due to severe stress, very high level of oxidant stress, then only they will go for hemolytic anemias. Then 60 to 150% is class 4, which is usually normal, and they will be completely asymptomatic. Type 5 is more than normal, at least excessive hormone activity. Again, you cannot categorize, this is completely asymptomatic. So these two will be completely asymptomatic. If they ask you among the deficiencies, the first 3 are important. If you talk about the deficiency, the first 3 are important. Among these first 3, which are the most common is type 2 and type 3. If you want a single answer is type 2. Type 2 is the most common among all the enzyme deficiencies. If you ask me, type 3 is little bit not that common, but it's very common in black population. Type 3 is very common in blacks, type 2 is very common in Mediterranean population. So that is why this is also called as G6PD Mediterranean and G6PD blacks, or you can call it as African Americans or G6PD A-. So other names for this type 3 is G6PD A- or G6PD blacks, but that's that's very common. At the same time, this type 2 is supposed to be very, very common in the Mediterranean population, but overall common is the type 2 only. Type 1 is actually quite rare. You don't get that often. Type 1 is very rare, where the patient will have a chronic, with trigger or without trigger, they will have a hemolysis in a chronic, over a chronic time. So these are the variants of G6PD which are discussed. In the deficiency happens in 1, 2 and 3 typically. And what are the triggers? I told you there are certain specific triggers and precipitating events are there. What are the triggers and precipitating events? The first one is the drugs. So a lot of drugs can trigger. Very important for exams are sulfonamides. It can be triggered with dapsone. It can be triggered with nitrofurantoin. These are very important commonly used drugs. Nitrofurantoin. It can be triggered with primaquine. Classic exam question. Then you can get with doxorubicin. You can get with rasburicase or pegloticase. I'm not writing pegloticase, rasburicase or pegloticase. Then you can get with dabrafenib. Then you can get with methylene blue, which is used in methemoglobinemia, which I discussed already. So in this exam question will be sulfonamides, dapsone, nitrofurantoin, primaquine and methylene blue. These are the very important things for exam. So many times asked question. In that the most important will be primaquine and the dapsone. Still more important if you ask me, primaquine and dapsone. These are the most important things that can result in your trigger for G6PD, hemolysis in G6PD deficiency. Second, it can get with infections. Infections, what is the problem is, I told you here already there will be some amount of NADPH is there. So NADPH has 2 purposes. Many purposes are there. The most important 2 purposes are, one is tackling oxidant stress. tackling oxidant stress. And second purpose for NADPH is respiratory burst, otherwise called as oxidative burst. So what will happen is, during infection, actually infections will increase the respiratory burst, and lot of NADPH will be actually shunted to respiratory burst, and already NADPH is reduced, and little is available for tackling the oxidant stress. That is why oxidant stress will increase during infections. So that is the reason why they cannot tackle here. So majority of the NADPH will be shunted towards the respiratory burst phenomenon only. So that's why infections are very important triggers for hemolysis. Then you can get with decay, diabetic ketosis, then certain food like fava beans. That is why G6PD deficiency caused hemolysis, also previously referred to as favism, isn't it? So fava beans also is there. So this also can cause our food favism. This also can produce something called hemolytic anemia, trigger for hemolysis in G6PD deficiency. And if you ask me how will you diagnose G6PD deficiency, clinical features of G6PD, I already told you majority of them will be asymptomatic. But if they are symptomatic, they come with intravascular hemolysis. Features of intravascular hemolysis, which can be either acute, which is very, very common due to some specific triggers, or it can be chronic even without triggers, but causes typically non-spherocytic hemolytic anemia. Usually intravascular hemolytic anemias will not cause spherocytes. Only extravascular usually causes spherocytes. It's intravascular predominantly. So spherocytes are very rare. And diagnosis wise, if you ask me how to make a diagnosis, in peripheral smear, you will see something called Heinz bodies, which we discussed already, and you might see this classic bite cells are blister cells, which again we have discussed in the RBC basic section itself, and in the pathophysiology in G6PD deficiency also I explained to you. Bite cells are blister cells, and there are two tests are there which are definitely for testing for G6PD deficiency. One is called fluorescent spot test, which is a semi-quantitative test, and second one you have something called the quantitative G6PD levels. Remember, both these testing should only be performed during the remission. You should not perform this test in acute stage. You should never perform this in acute stage. You should perform only in remission, which means when the patients are in stage where there is no hemolysis. Why this is very important? Because during hemolysis, definitely there will be reticulocyte production. So whenever there is a hemolysis, acute hemolysis, there will be increased reticulocyte production. This reticulocyte is fresh one. It's a new RBC. This fresh RBC, they may have a normal G6PD levels initially to come with. They may have normal G6PD, and all the RBCs, old RBCs, have gone hemolysis and they are dead now. So there is no RBC, only fresh new RBCs are there in the form of reticulocytes and new RBCs, which may have a normal G6PD levels, which means the RBCs that had low G6PD levels have already been destroyed in hemolysis. So the report may come as falsely normal G6PD. That is the reason why you should not check during acute hemolysis stage. You give time, and once the patient goes for remission, in the non-hemolytic stages, when the patient is not having anemia, that time you can go for the testing for G6PD levels. Treatment, there is no treatment. You have to just avoid the triggers. Maybe they might need transfusion, just to support during severe anemia and acute hemolysis. During acute hemolysis, they may go for severe anemia. That time you might need transfusion. Apart from that, you don't need any treatment for this as such. You don't have any treatment as such. You have to just avoid the triggers. That's all. So this is all explains the G6PD deficiency. Then we can go to the pyruvate kinase deficiency. So you know very well, pyruvate kinase is also an enzyme of Embden-Meyerhof pathway, that is glycolysis. You have pyruvate kinase enzyme here. What is the importance? Why pyruvate kinase deficiency may result in hemolytic anemia, especially extravascular hemolysis? Is because this pyruvate kinase step is going to yield one ATP. This pyruvate kinase step is going to yield one ATP molecule. So whenever pyruvate kinase is deficient, the RBC is going to have reduced ATP production. This is very, very important because RBCs is completely dependent on the glycolysis. RBC is not dependent on Krebs cycle or citric acid cycle or TCA cycle because it doesn't have mitochondria and it doesn't have any other cell organelles as well. So it completely depends on energy only for this glycolysis. In that glycolysis itself is going to yield only 2 ATP. In that itself you removed 1 ATP production. So RBC will suffer from low ATP. So again, to maintain the membrane integrity, you need that ATP to push the, for example, to work sodium potassium ATPase to work, you need ATP. No, like to maintain the membrane integrity itself, you need ATP production going on continuously in the cell. So if ATP production is decreased, so there will be reduced membrane integrity. Membrane integrity will be reduced. Since membrane integrity will be reduced and membrane is more prone for destruction and damage and ionic damage and all, flux and all cannot be adjusted by the pumps because ATP production is less. They will go for extravascular hemolysis when they are traveling to the spleen because of the fragile membrane. Typically they result in extravascular hemolysis. Very important. So once they result in all these things, so what are the features? Very important. These patients are typically autosomal recessive in inheritance, which means surely you will see a family history. Number one, and there will be features of extravascular hemolysis. Family history will be there, features of extravascular hemolysis will be there, and DCT will be negative, that is to rule out autoimmune hemolytic anemia in case. So negative direct Coombs test. At the same time, peripheral smear will show a lot of echinocytes. Lot of echinocytes in the peripheral smear. Clear? So that is what is going to happen. So how will you treat? Since it's typically extravascular hemolysis, the definitive curative option, if you ask me, answer is splenectomy. But it's not needed in most of the cases. Just supportive transfusion during acute sudden episodes of hemolysis, that is more than enough. But only curative option like hereditary spherocytosis, here also you have to go for splenectomy because predominantly it's an extravascular hemolysis where the spleen kills the RBC. So splenectomy will be the curative option. But apart from that, you can use conservative management like frequent transfusions also if you wanted to. So these are the problems due to pyruvate kinase deficiency. But if you ask me, so next one is the phosphofructokinase deficiency we are going to talk about. Where is phosphofructokinase? You see in the glycolysis very important at this step. But even though I have not mentioned one important thing, this fructose 1,6 phosphate will be converted to something called fructose 1,6 phosphate will be converted to fructose 1,6 bisphosphate, which is going to form this 1,3-BPG and all. So which is not mentioned here. That's why I put it as a dotted line here. Not mentioned in this diagram. So anyway, for this step you need a phosphofructokinase. So why this is important is, it's important for a variety of reasons. So once phosphofructokinase is deficient, the glycolysis cannot go on. The overall glycolysis itself will shut down. Glycolysis will shut down. So there are two reasons why this glycolysis is important, because once glycolysis is shut down, is reduced, two things depend on energy, completely on glycolysis for energy. One is RBC and second is the neurons. Second is neuron. These are the highly glucose dependent cells, which means without glycolysis they won't survive. So that is the reason RBCs may have reduced membrane integrity, resulting in extravascular hemolysis. At the same time, these neurons also suffer damage, resulting in seizure, mental retardation and all these things in this patient. So that is the reason. So because of reduced glycolysis and reduced energy production, ATP production, the neurons can have all these problems and RBs can go for hemolysis. But typically PFK deficiency is autosomal recessive, everyone knows that, and it's actually placed on glycogen storage disease type 7, which is otherwise referred to as something called Torres disease, which means it's going to have some muscle manifestation also. Let me tell you. So why it produces muscle manifestation. So you have a process called glycogenolysis. So glycogen will be converted to glucose by variety of steps, and this glucose will be again used by the muscle for energy by subsequent process. So if the glycogen can convert to glucose, but there is a block in the pyruvate kinase step, means this glycogen conversion to glucose and subsequent movement will be blocked at this fructose 6 phosphate step itself, which means the glycogen cannot break down any further and the glycogen levels will start increasing and the glycogen will start accumulating in the muscles. And you can see in the biopsy, actually in muscle biopsy you can see glycogen will start accumulating in the muscles and they cannot utilize the glycogen because of the block in the glycolysis step, conversion from glycogen to glucose. So once your glycogen cannot be utilized, so underutilization and muscle cannot utilize glycogen, which means there will be very poor energy production in the muscle, resulting in muscle cramps. within few minutes after exercise, they will result in muscle cramps. In worst case scenario, they can even go for rhabdomyolysis. So which means in this disease, the most important thing is the fatigue and muscle cramps. Just a few minutes after starting to walk or after starting exercise, they'll go for severe fatigue and muscle cramps. In worst case scenarios, they might even result in a rhabdomyolysis. And these patients will have increased serum uric acid also. Increased serum uric acid and hyperuricemia. Why increased serum uric acid? That is because I told you the fructose 6-phosphate levels will increase, the glucose 6-phosphate levels also will increase because there is a block here and it cannot proceed there. So all this will start increasing inside the cell. And lot of increased glucose 6-phosphate means you are going to shunt a lot of this excessive glucose 6-phosphate towards HMP shunt. Your HMP shunt. So your HMP shunt will produce more nucleotides. We know that very well because HMP shunt itself is for nucleotide production only. So no nucleotide production will increase by HMP shunt. So once nucleotide production is increasing, their breakdown also will increase, which means the turnover of nucleoside breakdown also will increase, which means the overall turnover will increase. The nucleotide turnover will increase. Once the nucleotide turnover increases, this is the reason for increased uric acid production. So that is the reason why these patients go for hyperuricemia, and some patients may have gout as well. That is also a possibility. And diagnosis wise, you can do a muscle biopsy where you see glycogen accumulation. Muscle biopsy where you can result in glycogen accumulation. There is no treatment for this disorder. There is no enzyme replacements also. Gene therapy is in pipeline, but I don't think it's going to be of any use in the next coming future at least. So these are the 3 enzyme deficiencies I told you. One is the GSP deficiency, which I have discussed in detail. Second is the pyruvate kinase deficiency, we discussed in detail, and the phosphocreatine deficiency, which also we discussed in detail, where the main problem is actually a glycogen storage disease, where the main problem will be in the muscle and the CNS. Extracellular hemolysis is an additional finding, and hyperuricemia is also an additional finding, which I have described how all these things are going to happen. And this brings up to the very short discussion on the enzyme deficiencies causing hemolysis. In the next section, we will be discussing on the immune hemolytic anemias.